Welcome back, and I trust you're all ready and rejuvenated for our next informative and captivating session. Please join me in extending a warm welcome to our next esteemed chair for the next session, Dr. Nisha Viji Varghese, neonatologist, Tawam Hospital, Al Ain, UAE. Please give her a round of applause. Doctor, the session is yours.
Good morning, everybody. So please join me in welcoming Dr. Niaz Ahmed. He is a consultant transplant and hepatobiliary surgeon at SKMC Abu Dhabi. He is also an honorary professor of transplantation at the Dow University of Health Sciences, Pakistan. To say too many words about this esteemed doctor is not enough, but I need to say he has been listed in the Guinness World Records since 2016 for performing the kidney transplant from the youngest donor. He is also widely recognized for his clinical and research work in the field of liver and renal transplant. Please join me in welcoming him to the stage. Dr. Niaz Ahmed.
Thank you very much for the introduction. Thank you, Dr. Junaid and Dr. Ayman for the invitation. It's really an honor to speak in your meeting. Just the disclaimer that I am, for people who don't know me, I'm not a pediatrician or a neonatologist, so please be kind to me when you're asking questions. In today's talk, I'm going to walk you through the scope of neonatal donation, organ donation from neonates and infants, and also the outcome of transplantation from neonatal organ donation. In the course of my talk, I'm also going to share with you some photographs, pictures of families and patients, and I have consent to do so. So I have no disclosure. For the purpose of this talk, I have simplified the definition of infants and neonates. The neonates, obviously, from birth after 36 weeks of gestation to 28 days after birth. And infants I have defined as from 1 month to 2 years of age. Now, the organs that can be transplanted from infants and neonates can be heart, lung, liver, and small bowel, and kidneys. Kidneys are the most frequent organs that are transplanted, and unique in a way that most of the kidneys that are transplanted from neonates will go to adults, unlike the other organs. So I'm going to limit my talk to the kidney donation and transplantation. So just an introduction of organ donation seen in the United Kingdom. This graph shows the organ donation year by year on x-axis, whereas the y-axis shows the percentage of the age group. So each column has the age group, the youngest at the bottom and the oldest at the top. So what we have seen over the last 2 decades, that the increase in organ donation has happened mostly in the older age group. So much so that 50% of the donors will be classed as extended criteria donors. Basically, that means that the outcome from these organs will not be ideal and suboptimal. And if you look at the bottom of these graphs, the donation from pediatric, and this is total pediatric from birth to 18-year-old, has remained constant in the UK and for that purpose in the North America, and it's about 3 to 4%. I don't know what happened. Yeah, okay. So this is accrued mortality data from Australia and New Zealand registry. Basically, it highlights one obvious fact, that we are vulnerable to dying at 2 extremes of ages. At the lower extreme in the pediatric, most of the mortality is concentrated in the perinatal and early infantile period. Whilst organ donation is extensively explored from the older age group, the donation from the infants and neonates are not explored fully to date. So we looked at the state of pediatric donation in the United Kingdom. We carried out a 15-year study looking at the pediatric donation and their outcome. What was striking that the donation from pediatric donors over 2 years of age, 2 to 5, 5 to 18, the referral, donation, and transplantation utilization were okay, in par with the adult donation. But when we looked at donation from birth to 2 years of age, we found that over a 15 years period, only 17 transplants were done. So about 1 transplant a year, and we thought the scope of donation is much bigger than this. And this 17 donation, the minimum age was 11 months, and there were no neonatal donation. So we looked at some of the audits. This is the audit, This is the audit done by Joe Brearley in Great Ormond Street. He looked over 6.5 years, all the infants and neonates up to 2 months of age. He looked at 84 infants and neonates and found that 45 of these, that is 54%, could qualify as potential donors. Obviously, none were referred for donation. Our own neonatologist, Joe Wright, in Leeds General Infirmary in Leeds, looked at neonatal deaths in our NICU, and she audited 199 deaths over a 5-year period. She applied more stringent criteria than Joe Brearley to qualify for donation and found that 18 could have been potential donor, but only 1 of these proceeded. We also took a snapshot of UK national neonatal mortality, and in 2013, there were 1,436 deaths. If you extrapolate the 2 audits, so first one of Joe Brearley and the next one of Joe Wright, anything from 9% to 50% or 54% of these neonatal deaths could have qualified as potential donors, but no donors were referred in 2013. So there are some real and the perceived anxieties against transplanting kidneys from neonatal donors. The first one is, we may have a reduced nephron mass, and it may be adequate to provide good renal function in the long term. We can miss renal dysplasia in the neonates. There is a risk of proteinuria after transplantation, which can lead to ultimately renal failure. Risk of hyperfiltration injury and glomerulosclerosis is also real. The last 2 are surgical, technically complex. There's no denying that these procedures are complex, takes long time, and the early complications and graft loss are more than in adult transplantation. But we studied all these factors and found that these factors are all surmountable. Firstly, we are born with 1.4 to 1.4 million nephron in each kidney. And these numbers are finalized at 36 weeks of gestation. So there is no increase in number of nephrons after birth. The kidneys increase in size due to hypertrophy, not hyperplasia. The incidence of dysplasia in countries with good antenatal care is 1 in 2,000 live births, so we don't need to worry about it. Proteinuria is common after transplanting neonatal organs, but it usually resolves within a year. Hyperfiltration injury due to high blood pressure is a real risk, but can be overcome by careful patient selection and aggressive control of blood pressure after transplantation. And the surgical challenges, that's what we are here, the procurement, preservation, back table implantations are all challenging but surmountable. Similarly, the early graft loss mostly due to vascular thrombosis is also surmountable. So we put together a simple criteria for considering neonatal donors. So 36 weeks of gestation or 2.5 kilogram, this is conservative. Normal antenatal development scan, evidence of urine production after birth, serum creatinine of less than 50, and of course, absence of infection. If the child is within 72 hours of birth, maternal creatinine could be taken as a guide. When we accept these donors before term, we use only two criteria to consider these as donor. Evidence of urine in the bladder and no oligohydramnios. So it is surprising to know, and I was also surprised when we embarked on these transplantations, that diagnosis of brain death was not allowed in infants under 2 years of age in the UK up until 2015, when the work group started, and eventually it was allowed in infants under 2 years of age. And the first DBD neonatal donation in the UK happened on 16th of October 2016. So this is fairly recent. Now, despite the passing of the law, as you would imagine, the DBD donation has not been embraced fully in the UK or in the USA. So most of the donor we get from this age group are DCD donors. We also put together a simple criteria for accepting recipient for these kidneys. The recipient has to be young with low BMI. So 60 I put in, so less than 60 years of age and less than 60 kilogram in weight, although these are flexible. No hypertension or well-controlled hypertension on 1 or 2 agents. No diabetes mellitus, particularly long-term or uncontrolled diabetes. No peripheral vascular disease, and the recipient should be a non-smoker. And of course, we take informed consent from these potential recipients, and this is done in clinic setting, not on the day of the transplantation. Now, procurement from neonatal and infant donors are also challenging. The important features in this neonatal and infant donation is that the flushing of the organ and the cooling should be done in situ. And second important fact is most of the time, the kidneys will retrieved en bloc, both kidneys together on aorta and IVC, and often with other organs. I don't know whether this works or not. Yeah. So here you can see the en bloc, all the abdominal organs except the small bowel, the liver, gallbladder, the pancreas, 2 kidneys, then the ureters. And this neonate also had bilateral adrenal hemorrhages, which you can see here. This is another picture to give you a perspective of the size of all the abdominal organs when we retrieve en bloc. This was our first neonatal donor. Again, gives you the perspective of the whole organs. The liver, pancreas, kidneys can fit in the span of your finger and the thumb. And the kidneys can fit side by side on two fingers. So meticulous back table dissection is paramount in these kidneys. This is being done by Dr. Jamil and fellow. Dr. Jamil is a consultant now. And this, of course, is in the middle of the night. And the process takes anything up to 2 to 4 hours to get these kidneys ready for transplantation. We take extreme care not to dissect too much in the hilum here. And we use the technique of a sandwich between two pieces of gauze. We sandwich these kidneys to prevent rotation on its pedicle, which can be catastrophic if it happens. But despite all the efforts, sometimes these kidneys are not flushed inside you. As you can see, this kidney is red. There is blood inside it. So we use hypothermic machine perfusion to get the blood out, condition the microcirculation, and get these kidneys ready for transplantation, as you can see in the next picture. We use a modified technique to implant these kidneys into an adult recipient. This technique is developed in our center in Leeds. So we try to transplant the kidney very low in the pelvis on the external iliac vessels with the shortest possible ureter, which are transplanted separately onto the bladder. And you can see these kidneys after reperfusion, nice and pink. I call them happy kidneys. So postoperatively, we use a standard protocol for immunosuppression, intravenous fluid, and antimicrobial. What is different is we use heparin intraoperatively and postoperatively, low-dose heparin for 5 days to prevent graft thrombosis. We also place these patients on aspirin for a year to prevent vascular complication. But most importantly, we manage the blood pressure aggressively to prevent hypertensive glomerulosclerosis and subsequent graft failure. Postoperative monitoring for us as a surgeon is just the ultrasound scan. And on the ultrasound scan, we are looking for perfusion only, or at least I'm looking for perfusion only in both the kidneys. As long as the kidneys are perfused, they will work most of the time, but will take their own time. So here you can see, I think, I'm really sorry about this, temperamental. So kidneys side by side, and both kidneys are well perfused. In the earlier part of our experience, we use MAC3 scan to identify the uptake and excretion by these kidneys. And you can see in these pictures, these kidneys light up beautifully by technetium 99, and after a little while, this technetium is excreted into the bladder. So that gives us a lot of confidence that these kidneys are going to work. Now, physiologically, the creatinine clearance initially will be very slow, but once it establishes, it continues to grow over weeks, months, even beyond 1 year. Anatomically, this is the questions I get asked more commonly. Will these kidneys grow? Yes, these kidneys grow, and they continue to grow beyond 1 year. But most of the growth we have seen happen within the first 6 months after transplant, within the 6 weeks after transplantation, actually. So we published our results from these transplantation a few years ago in AJT. The journal insisted, the journal insisted that we divide our cohort according to weight rather than according to age. So that's what we did. We divided our cohort into 2 groups, less than 5 kilogram and more than 5 kilogram. Coincidentally, we got 15 in each group. The 15 in the less than 5 kilogram Out of those 15, 13 were neonates. Now you can see the median age is 6 days and the median weight is 3.4 kilogram in this group. And I'm going to mainly focus in this group today. So out of these 15, we had 2 early graft losses, one due to vascular thrombosis, graft thrombosis, and one due to primary non-function. And this is the problem with all pediatric graft, more or less, but more so in the neonatal donor group. But we ended up with 1-year graft survival of 86.7%, which is slightly lower than what you would expect in adult organ graft survival. Whereas if you look at the group in the 5 kilogram, above 5 kilogram group, the graft survival was similar to what you would expect from adult transplantation. So what was characteristic? I have mentioned that there is early graft loss. Early graft loss due to complication, primary non-function or vascular thrombosis, but after that, the graft survival is steady. But what is more striking is the bottom graph of the renal function, less than 5 kilogram on the left-hand side and more than 5 kilogram on the right-hand side. And in both groups, you can see that the serum creatinine and the GFR is increasing. And I have plotted only 12 months, and you see in 12 months, they achieve a GFR of 70, anywhere between 70 to 90 mils per minute, which is better than you expect in living donor renal transplantation. But this was not easy in our early experience. This is the graph plotted by our research fellow, Imeshi, of all individual patients, is the first 10 recipients. So we didn't know in the first 2 months which way these kidneys are going to go. So that the creatinine were all over the places. And it wasn't up to 2 months' time when we started to see a trend of creatinine going down, and by 6 months, they all achieved a steady state. So Tropman and Perez are 2 gentlemen from UC Davis and California, so they have the largest experience of doing these kind of transplantation. And in fact, they get kidneys from all over North America sent to them from infants and neonates for transplantation. So they coincidentally published their outcome in the same year as we published our results, with strikingly similar results. They have not mentioned the number of neonates in their cohort, but looking at the age and weight on their cohort, it appears that they did include a significant number of neonates in their cohort. But coming to the results, they also show that there is a graft loss in early period, followed by steady graft survival over a long period of time. And also, as I mentioned, that kidney function continues to improve over 1 year, even beyond 1 year. They have plotted up to 6 years and giving a kidney function better than the living donor transplantation. Our own experience has evolved over several years. In 2008, a 2-year-old DCD donor was our youngest in the UK. Since then, we did a progressively younger and smaller donor kidney transplantation. We did our first neonatal donor transplantation in 2014, and that was a DCD donor, and we did our first neonatal DBD, donation after brain death, in 2016. We also carefully and regularly put our observation and outcome in scientific journals for peers to scrutinize and reproduce if they wanted to. Now I'm going to go through two cases to highlight the impact of these transplantation. So this is baby Hope. She was a female anencephalic twin, was accepted for donation at 24 weeks. So I must say that we do not approach these mothers. They come to us wanting to donate. So we monitored her closely, and the baby had normal renal development. The mother underwent cesarean section at 36 weeks. The baby Hope survived 69 minutes, plus 5 minutes mandatory no-touch time, so 74 minutes. So if you are looking at Guinness Book, it will say 74 minutes. And baby Hope weighed 1.3 kilograms. We gave the kidney to a 26-year-old female who weighed 60 kilograms. While we were operating, both kidneys perfused really well, but after a few minutes, one kidney turned black, thrombosed. So we took this kidney, detached this from the aorta, the renal artery detached from the aorta, and put it onto the inferior epigastric artery. We had good perfusion. We wiped our sweats and closed the patient. But postoperatively, again, questionable perfusion of this kidney. And day 2, day 3, no perfusion. So we took her back to theater operating room on day 4. And as expected, this kidney was ischemic, black, so we removed this kidney. Now, this recipient is 7 years off. Last time I followed her up was 5 years. At 5 years after transplantation, her serum creatinine was 71 micromoles per liter. So this is the intraoperative picture. Of course, I did not take the picture when the kidney turned black because everybody was stressed at that time. But what I can show you, this is the kidney which had turned black. And this is the external iliac artery, as you can see this one, and inferior epigastric artery. So we put it onto the inferior epigastric artery, and the kidney perfused, nice and pink. But then this is 4-day on exploration, the kidney was black, so we had to remove this kidney. So now you have to imagine the baby Hope is 1.3 kilograms, and Sabrina Begum, 26 years old, adult, and she has one kidney from baby Hope, and we are watching it quite nervously. So this recipient did not look back, and she had progressively good kidney function, and at 5 years her creatinine, as I mentioned, was 71 micromoles per liter. Baby Hope made it to the Guinness Book in 2016 as the youngest donor who survived 74 minutes after birth. But before baby Hope, our first donor was Teddy, who survived 88 minutes after birth, and he also made it to the Guinness Book. To summarize, organ donation from infants and neonates expand the donor pool. I think it provides the child and the family a chance of a lasting legacy. Babies are born with adult kidneys. They have the best nephrons. I call them the Rolls-Royce of kidneys. Kidneys from infants and neonates work well in adults. Long-term graft survival and functions are excellent. Early graft loss can be mitigated by focused experience in high-volume center. Lastly, I wanted to say that as clinicians, we don't work in a void. There is a patient and a family behind our efforts. So Carrie-Anne Bray was 22-year-old. She was generally fed up with dialysis and life in general. She received the kidneys, 2 kidneys. Of course, we transplant both the kidneys in one recipient from a 23-day-old neonate who had died of cardiac hypoplasia. This picture was taken at her first anniversary after transplantation. She also wrote us a long letter. I have put some excerpt at the bottom. So this is Carrie Ann with her entire family, father, dad, mom, dog, and then sister, 3 brothers, and her fiance, this one. Carrie Ann subsequently got married and had her own child, own baby. This one here. But this is an iconic picture, 8 years after transplantation. 8 years after transplantation, they were actually united by the Duggleby family, the donor family. So this is the Duggleby wife and John and their children. Really sorry. So Anne Duggleby and her husband decided to donate the kidneys of Minnie, who died of cardiac hypoplasia. This then went into transplant Carrie Ann, who got the gift of a normal life, who was on long-term dialysis. So this is a legacy which is left by Minnie after her death. Of course, this kind of work is not a one-person work. I got all the introduction, but there's a big team behind it, and every single one of them needs an acknowledgement. But I want to mention some of them. Claire, Kate here, they are our coordinators. They knew the waiting list like the back of their hand, and they took most of the phone calls for me. I worked with really progressive nephrologists, Richard Baker, Tas Newstead, Sunil here hiding. I'm here at the back. Imeshi, I want to mention, she was our research fellow, now a consultant in Manchester. She kept all the data prospectively to look at our outcome. Thank you very much.
Now, it's with great pleasure I invite Dr. Mughizur Rahman, consultant pediatric in neonatology at the WAM Hospital. He has over 3 decades of experience in pediatrics and neonatology, working across the GCC and Pakistan. He has a keen interest in neonatal neurology, especially in brain protection in term and preterm infants. He's extremely well-read, well-versed, and he has an active role in all our research publications within the unit. It gives me great pleasure once again to invite Dr. Mughizur Rahman to the stage.
Thank you, Dr. Nisha, for a nice introduction. I would like to say thanks to Dr. Ayman and Dr. Junaid to give me this opportunity to talk in front of you. I'm going to talk about a very important topic that is post-hemorrhagic hydrocephalus. And post-hemorrhagic means post-intraventricular hemorrhage leading to the hydrocephalus. And this is one of the hot topics because there is a lot of variation about the management of this issue. So in the next 20-25 minutes, I would like to share with you what is the current data and what is the evidence and how can we devise the guidelines to manage this problem. I have nothing to disclose, and the objectives of my talk are to discuss the pathogenesis of post-hemorrhagic hydrocephalus, and then I will talk about monitoring of post-hemorrhagic hydrocephalus, and when and how to intervene. You can see here that we have increased survival of the preterm infants by the good and advanced neonatal care, but still the IVH prevalence is quite high. In this slide, you can see here Romania, Switzerland, and in the 2 periods of USA. If you look at the USA, you can see by Stoll, it was published in 2010 that the rate of IVH was around 30-35%. By the advanced care, we're able to reduce it to around 20-25%, so no substantial decrease in the IVH. So IVH is still a big burden among the small babies. And if you look at the Canadian neonatal work, they have a quite high incidence of IVH. You can see around 50-60% infants, especially below 25 weeks, they do develop IVH. So IVH is quite a bad problem, and this is a Cochrane meta-analysis, and it shows that even the grade 1 or 2 IVH carries the bad prognosis. It increases the high odds to have the poor neurodevelopmental outcome. So pathogenesis is very important to understand here. You can see on your left-hand side, this is a germinal matrix, and this is a microscopic picture, and that shows that how the blood is there in the germinal matrix. And germinal matrix, you all know, is a production. It produces the progenitor cells for the myelination. Yeah, you can see here in this. Yeah, this is the microscopic picture of the germinal matrix. And the germinal matrix is the first place where the bleed happens because it has a very tiny, fragile vessels. And germinal matrix is present in the premature babies up to 32, 34 weeks. So that's why the babies we screen below 32 weeks, because that is the area which has a higher propensity for the bleeding. This bleed, if it increases, it goes towards to this position. You can see here, this is a grade 3 IVH when the bleeding is filled, the ventricles are full of blood. So this is not the pathogenesis of IVH. It is not so simple, initially it was thought that IVH is just the blood in the ventricle, but when you look at the cellular level, it has a lot of consequences. So when the blood sets into the ventricular system, it has the lysis, and it releases hemoglobin, iron, and complement. And all these 3 things, they induce inflammation, oxidative stress, and glutamate toxicity. And in turn, they all lead to axonal damage, and it turns to be having a reduced myelination and white matter injury. So even the alone IVH leads to poor neurodevelopmental outcome based on this. And if there is IVH and it blocks the CSF pathways, it results into a hydrocephalus. This is the model which is developed recently by the Hydrocephalus Society in USA, and they're working on all these cellular events. There is alteration of the CSF dynamics that causes the inflammation in the choroid plexus, and that leads to higher production of the CSF, then inflammation, then there is a destruction of the microglia, then there is ependymal injury, and also the absorptive services. This model, keep in mind, we will talk about the recent developments on the management of this issue. When you look at IVH in a gross way, then there is clots. They lead to early ventricular dilatation. Clot lysis, we already discussed. It looks like that it could cause the resolution of the ventricular dilatation, but the clots can block the CSF pathway. Usually it blocks the aqueduct as well as the foramen magendi and Leschka. And it can cause the obstructive hydrocephalus, but this is not a common problem. The problem is the blockage of absorptive channels. The previous theory was that there is arachnoid granulation inflammation, but the recent evidence does not support that, because arachnoid granulation, they don't develop in a very premature baby, but when they are around 34 weeks, they can cause the arachnoid granulation inflammation. But now the recent evidence said there is a lymphatic problems, and the lymphatics absorption get affected, and that lead to the communicating hydrocephalus. I earlier mentioned IVH itself carries the bad prognosis. But on the top of that, if the IVH leads to post-hemorrhagic ventricular dilatation, it carries the further worse prognosis. Almost 40 to 50% infants after grade 3 to 4 IVH develop post-hemorrhagic ventricular dilatation. And there is a clear evidence now, which I will show you now in the next slides, that it carries the further worsening of the neurodevelopmental outcome. This is one NICHD data, and this slide showing you 4,216 infants, and they looked at the infants, the premature infants with post-hemorrhagic ventricular dilatation, intracranial hemorrhage without post-hemorrhagic ventricular dilatation, and the infants who have normal ultrasound at the screening. And you look at this figure, and you can see here that when there is intracranial hemorrhage without dilatation, the death and neurodevelopmental impairment is around 39%, but it goes up to 68% when there is a post-hemorrhagic ventricular dilatation. And in the same way, the cerebral palsy and neurodevelopmental impairment, it substantially increased after this complication. And the predictors of death and the severe neurodevelopmental disability is this post-hemorrhagic ventricular dilatation that needed the intervention. That means the either reservoir or shunt. And you can see the odds goes very high here. So odds very high here when you have the post-hemorrhagic hydrocephalus that needed the intervention. This is a very interesting slide, and I think you need to focus on this slide. This is a very old study done by Dr. Volpe and colleagues, and it was a multi-center study, involved the US as well as the New Zealand centers. And they looked at the retrospective data. And this slide is very important to understand the course of post-hemorrhagic hydrocephalus, especially when you are talking to the parents. So look at that. They looked at the 221 infants, and they recruited those patients who developed IVH, and they survived. And out of these 221 infants, 50% babies that did not develop ventricular dilatation. But 49% of this cohort developed the ventricular dilatation. And the interesting thing is that when they followed these patients very carefully, they noticed that 24 or 25% of the babies who developed dilatation after the IVH, they got arrested. Only 25% of this total cohort continue to have the progressive ventricular dilatation on the serial ultrasound. And another interesting thing is that out of this 25%, another 38%, they got further spontaneous arrests without intervention, or another 14% needed only temporizing Meyer's live lumbar puncture or ventricular taps. And only out of all these infants who develop post-hemorrhagic ventricular dilatation, only 17% required the surgical intervention, and almost 74% babies, they recovered by its own. So this is very important that this problem can resolve by its own. You need to buy the time only, and you need to do the serial follow-up for these patients. The same cohort, then they looked at that what was the grades of IVH which can lead to the post-hemorrhagic ventricular dilatation. They noticed that the most important was the grade 3 and 4 IVH who developed the ventricular dilatation. But you cannot ignore grade 1 and grade 2 IVH, because there were 4 babies who developed post-hemorrhagic ventricular dilatation even after grade 1 IVH. And in the grade 2, 12% they had the dilatation, and 2 needed the even reservoir and the shunts. So we cannot ignore even the grade 1 and 2. We need to carefully follow these patients. Now, the second question, how to monitor the post-hemorrhagic hydrocephalus. This is a big debate among the neonatal fraternity as well as the neurosurgeons. What we see, what we read in our medical school and in our clinical care, the course and career, the increasing the head circumference, bulging fontanelles, playing of the sagittal suture, apneas of bradycardia, these are the the conventional teaching clinical signs and symptoms. And based on these clinical signs and symptoms, most of the people go for intervention. But the recent data does not support this, because when you follow these signs and symptoms, it's too late for you to intervene. And the reason I will show you in the next few slides, that when you do go for a late intervention and you wait for these clinical signs and symptoms, the babies will end up with a bad or poor neurodevelopmental outcome. And why these clinical signs and symptoms are very late in the tiny babies, because you see in this picture, they have very wide subarachnoid space relative to the term infants. And due to that, this pressure effect is too late, and the symptoms, they appear very late. So there is a poor correlation of these clinical symptoms with the ventricular dilatation. And another thing is that the brain parenchyma of the premature baby is very compliant, so it absorbs a lot of pressure and it does not display the clinical symptoms. So how to monitor? So this is a question. Second thing is that, which has been worldwide accepted now, to do the serial ultrasounds in the babies who develop IVH by the ultrasound measurements. And the classically is we measure ventricular index, and that is called Levine index, and then anterior horn width and thalamo-occipital distance. There are certain other measures with the neurosurgeons that do that is called Avon ratio and fronto-occipital horn ratio. They do it on the MRI scan or the CT scans. But for neonatologists, these three measurements are very important. And over the period of last 20 years, the centile charts have been developed. And you can see here in this figure, you need to draw, this is a coronal view, and you need to take it at the foramen Monro level. You need to do at the foramen level, more the third section in the coronal view, and you need to measure the distance from the midline to the lateral part of the ventricle. And then you plot it on the centile chart, which I have shown you here. Levine as well as the Liu, they put this centile charts. So if it is touching to the 97th centile for the respective gestational age, that is the area where you need to have a very close surveillance. Second is the anterior horn width. It's the same section in the coronal view, but it's the diagonal measurement of the anterior horn. And the third, at foramen Monro level to take a section. And the last is thalamo-occipital distance. And this is in the parasagittal view, and you can see from the edge of thalami, you take the measurement to the posterior horn of the ventricle. And the centile charts has been developed. Normal is around up to 25 millimeter. So now I will just let you know what is the difference between the post-hemorrhagic. There is two, the overlapping terms people use. One is called post-hemorrhagic ventricular dilatation, and it is called post-hemorrhagic hydrocephalus. So there is a very little difference between two. When your ventricular index is at 97 centile, that is called post-hemorrhagic ventricular dilatation. But when it exceeds 4 millimeter above 97 centile, then you label it as a hydrocephalus. So hydrocephalus in the premature baby is based on the ultrasonographic measurement rather than on the clinical features. This is a very important point which I want you guys to notice. There are different types of post-hemorrhagic ventricular dilatation. I took this from Volpe, textbook of Volpe, and they say slowly progressive. They are up to less than 2 weeks, then persistently progressive. They continue to progress even after 4 weeks, and the rapidly progression is that they progress within 7 to 10 days, and most of the babies, they get arrested. Now, the question, when to intervene? This is a big debate over the last 10 years. Shall we intervene when the infant is clinically symptomatic? Of course, no. I already addressed this. Now, the second question, shall we intervene when the ventricular index is 4 millimeter above the 97 centile based on ultrasonographic measurement, or ventricular index at 97 centile? This question was addressed by a very big randomized control trial, multi-centered, and it is so far is the only very good control trial that is called ELVIS trial. And it was a multi-center study. Dr. Linda DeVries and from the US, the centers were involved in this study. And they looked, what they did, they looked at the babies with intraventricular hemorrhage and post-hemorrhagic ventricular dilatation. And they divided into the two groups. One group with the early intervention was that when the centile ventricular index was at 97 centile. And the second group, they intervened when it was 4 millimeter above the 97 centile. Then they look at the short-term outcome, they could not find any difference in the death or the VP shunt. They were more or less similar in the both groups. Even the VP shunt was similar in the both groups. But when they looked at later on, the babies who were in the early threshold group as well as in the late threshold, even when they had the shunt required, the babies in the early threshold group have the better Bailey's motor and the cognitive scores. And when they looked at the post-hoc analysis, they reached to a conclusion that earlier intervention was associated with the lower odds of deaths or severe neurodevelopmental outcome in the preterm infants with progressive post-hemorrhagic ventricular dilatation. In the same cohort, they did another study and they looked at Kido-Koro scores based on MRI, and they did MRI at a term equivalent age, and they noticed that the infants who were in the low threshold group, they have the better Kido-Koro scores. They have a lower scores. It means they have a better brain volume. So that was also one encouraging thing by the data. Later on, Dr. Eldeeb and colleagues, they compared this data of ELVIS trial with from the North American data, where the intervention was done based on ventricular size. And you can see here in this figure, there is a red line, the blue line, and the yellow line. So red and blue is the ELVIS data when the interventions were done, when the anterior horn width was less than 10 millimeter. But you look at the yellow line, where the North American data, when they intervened, their ventricular dilatation was very, very high. It was more than 20 millimeter. So the intervention was very, very late. So when they looked at this data, and they noticed that the North American study showed the lower cognitive and the motor scores in the cohort, while the ELVIS have the better neurodevelopmental scores. So that was another encouraging result of early intervention. And that gives you an idea that ventricular size is very important. This is a meta-analysis in which they try to look at the timing of temporizing measure and association of the neurodevelopmental outcome. And they reached to a conclusion that if you do an intervention later, then it has a more stronger association to have the poor neurodevelopmental outcome in this meta-analysis. So this is, so far I conclude that the later you intervene, there is a higher chance that the babies can have a bad neurodevelopmental outcome. DRIFT trial, it is very important to measure because this trial was a very brave trial. It was done by Dr. Whitelaw in Bristol University. And what they did, he had an assumption that if we remove the clot from the ventricular system, then it could reduce the brain injury in this cohort. But they could not find a very good result in the short-term outcome. But later on, when the data was looked at the 2 years, they noticed that the psychomotor and the mental developmental index scores or severity of neurodevelopmental outcome was lesser in the group in which they have this drainage and fibrinolytic therapy. So I'm running short of time, so I will go a little faster. And even they followed the same cohort at 10 years, and they had the babies with the DRIFT group, they have the better neurodevelopmental outcome. Now, how to intervene? This is a third question. Traditionally, we do the lumbar punctures, we do the ventricular punctures, we do the reservoirs, we do the subgaleal shunt or EVD. EVD is out of practice now because it has a higher risk of infections. Subgaleal shunt and reservoirs are very common practice. And there is no difference if you do the subgaleal shunt or ventricular reservoir in terms of infection, obstruction, or intracranial hemorrhage. The new thing which I want to highlight here is a neuroendoscopic lavage. And this has been done in Europe. Europeans are very brave to do these things. So the first study was done by Schulz et al. And they recruited 19 patients in their study, and they did the neuroendoscopic lavage. And they noticed that the shunt dependency was lesser in the group who had a neuroendoscopic lavage. And there are a lot of studies later on, all coming from Europe, Turkey, Spain, and Germany and Italy. And the very important finding of all this, when you compare with the all temporizing measure, you can see here the arrest of hydrocephalus was 43.4% in comparison to around 15 to 30% in other temporizing measure. So this could be a very good evolving thing in the future. And Congress of Neurological Surgical Systemic Review also recommend recently in 2020 that neuroendoscopic lavage is a feasible and a safe option, and therefore may be used for the removal of intraventricular clots and may lower the rate of shunts placement. This is the Congress, the conference was held in 2019 in New York, in which they looked at the cellular level and the strategies how to reduce the complications of IVH and post-hemorrhagic hydrocephalus without surgical intervention based on this model. There are a lot of experimental data, and that is very, very assuring, especially to use the antithrombin, iron chelator, anti-inflammatory COX-2 inhibitor, thyroxine, and stem cell therapy. But all data is in animals, and they are showing better myelination and better outcome. Only one study so far for the stem cell is from Korea, in which they recruited 8 or 9 infants, and they have seen that those infants have better outcome. But still, it is going on. So after all this evidence, Dr. Deeb and colleague, and this is not Dr. Deeb alone, Dr. Terry Ender, as well as Dr. Linda De Vries, they given this guideline, and I think we should lead to a consensus with our neurosurgical team on this color-coded, stratification and for the intervention, but you need to develop the consensus among your neurosurgeon. The approach here is that you need to follow the ventricular index. When it is at 97 centile, you need to be more serially doing the cranial ultrasound. When it is 97 centile and above, you need to think about intervention like lumbar punctures or ventricular taps, followed by temporizing measure. And when 97 centile and above 4 millimeter, you need to react fast and you need to intervene. So in conclusion of my talk is that post-hemorrhagic ventricular dilatation continue to be a significant problem that carries the poor neurodevelopmental outcome. Evidence is robust in favor of early intervention by monitoring the ventricular measurements. The neuroendoscopic lavage is feasible and a safe option as a temporizing measure to remove the clots. However, more expertise and data is required to implement this in the clinical practice. Thank you very much for your attention.
Hello. Thank you, Dr. Mukesh. Please join me in welcoming Dr. Hafiz. He's a consultant neonatologist at the Cornish Hospital in Abu Dhabi. He's trained in India and the UK, having worked at the Liverpool Women's Hospital before joining the team at the Cornish Hospital in Abu Dhabi. He has a spectrum of interests varying from clinical neonatology to medical research, quality improvement, and several other niches. Please welcome Dr. Hafiz.
Hi, good morning, everyone. Thanks for the kind introduction. And thank you to Dr. Junaid and Dr. Rahmani and the scientific committee for giving me this opportunity. So what I'm going to try and talk through in the next 30 minutes is something which we all struggle with when we are faced with a potential delivery of a baby at the margins of viability? Is it time to rethink the limits? I'm glad that it's a pre-lunch session, otherwise I ran the risk of putting you to sleep. I hope I can keep your attention for the next 30 minutes or so. So, that's not the end of my talk. You'll have to listen to another 30 minutes of it. This is a conclusion I came to when I gave a similar talk maybe around 8 years ago. But let's see what's changed since then. So you've heard this over the last 2 days. Interest in premature babies is not new. It's been going on since the turn of the century, where there were a curiosity. Then it became a reality that they could survive. But in the middle of last century, people started querying, is it worth it? Is the outcomes good enough for us to keep doing what we're doing? And we all know the answer to that. Yes, to a large extent, it is very well worth it. And since those times when the days of hyperbaric oxygen in a box has changed, technology has advanced, our understanding of the physiology has changed, and we have progressed from there. But when you talk about prematurity and its contribution to neonatal mortality, as a proportion, not much has changed in the last half a century or more. So when the WHO looked at it in 1950, it was still the largest contributor. It still continues to be. So maybe 10 years ago, they had this development goals. One of that, reduction of prematurity and the contribution of mortality from prematurity was one of the goals. But 10 years on, it still continues to be the largest contributor of neonatal mortality. And across the world, I have to chase this dot. It's different. The highest contribution of neonatal mortality rate from prematurity is more in Southeast Asia and Africa. But the kind of babies whom we are losing there is not the same what we lose in more developed economies. These are probably more mature babies. There's a lot more which needs to happen. That brings us to a question, so at the limits of viability, what should we be doing? I'm trying to explore what we should be doing more in the local context. To that, we have to look at both our local data and international data. So what is viability? So is it the point at which a newborn is capable of extrauterine existence, regardless of the length of quality of life? Or is it the ability to survive and to grow and develop normally? What's normal for me might not be normal for you. What's acceptable for one parent might not be what's acceptable for another parent. So it's a gray zone, and I think the answer lies somewhere in between. And when you start talking about the age of viability, when I was a medical student nearly 35 years ago, anything below 28 weeks was an abortion. For us, a 28-week baby is a good baby these days, with a very good outcome. And progressively over the years, it has come down to 26 weeks, 23 weeks, and we are now knocking on 22 weeks. And soon the DOH will be publishing its guidelines where anything about 22 weeks and you resuscitate will be counted as a live birth. Hitherto, anything below 24 weeks wasn't counted as a live birth. And over the last many years, we have had these miracle babies being reported in media, the smallest baby to have survived at 21 plus 6 weeks, really? Maybe. And not only from the US, from all over the world, we have these reports. So does that mean this is the norm? Probably not. So to understand what we should be doing, we obviously need to look at outcome data, and people started looking at it in the late 80s and from the mid 90s. So I'll look at some seminal publications which came out without going into too much detail. So when I was a trainee in the UK, this was one of the first studies which was published, the EPICURE study, which looked at population-wide outcomes of babies born at the margins of viability in England and Wales. And there was a parallel study happening in France at the same time. So what we can see, so I'm not going to go through the whole table and bore you. So at 22 weeks, there were very few survivors at that stage in 95. If I can get the pointer working, yeah. And as you go across the gestation age spectrum, more and more babies survive with an overall survival rate of around 40%. And out of those, half of them did quite well with mild or no disability. A quarter of them had severe problems, and a quarter moderate. And when they followed up at 11 years, problems didn't end there. So at least half of them had low test scores when their IQ was tested in school. The school performance across domains were worse compared to their peers. Does it matter? Maybe. It depends on the society you live in. It depends on the expectations of the society. To the individual, does it matter? It may or may not. So these are all gray zones, but problems persist into older age and even adulthood. All these babies from those cohorts are now becoming adults, and it's becoming increasingly understood that it's just not the developmental issues, they're facing physical health problems as a consequence of their prematurity. And at age 11, quite a few of them were attending special school in the UK, and up to 60% of them had what's called special education needs, which means they needed extra support in school. And there were more psychiatric issues and even autistic spectrum disorders. EpiPage study in France, similar study, but the guidelines in France at that time were quite different. Most of Europe at that time, except for the Scandinavian people, were not touching anything below 24 weeks. And they looked at that. So you can see how different data from different countries look, even for the same group of babies. So in France, more of them died at delivery, probably because they looked at them and said that it's not worth progressing and left them to die there. Of course, more got admitted to an ICU in the Epicure cohort. And when you look at survival of admitted, the French study looked better. That's probably because the babies were not that good by being left out to die earlier on. So it's important to understand when looking at data, what we see in one country is quite different based on what the local guidelines are, what the local cultures, and what the laws are. But when you look at the follow-up, very, very similar. Around 13% of them at 8 years had cognitive delay, 20% of them had cerebral palsy, the same issues, hyperactivity, emotional problems, peer problems, and higher risk of learning difficulties at 8 years. And my ex-colleague in Liverpool, Richard Cook, and all of them have looked at these children when they became adults, and most of them were in low-paid jobs, had difficulties forming social relationships, were not in steady relationships, but they were nicer people, less criminality. But they were struggling even as adults, but we have a minority of them doing quite well as well. So then people started looking at trying to lay down rules. What should we be doing with these babies when we're faced with them? So this is one of the first publications which came out in the UK when I was still a trainee in the mid-2000s from the Nuffield Bioethics Council. And this was a guideline they kind of put out, and which was later adopted by the British Association of Perinatal Medicine. Just looking at the 23 weeks. So they said anything below 23 weeks, we would give precedence to what parents wish. If they said don't do anything to the baby, let them die. Below 22 weeks, we won't even look at them unless for some reason parents kind of insist you give them a chance. And below 22 weeks, they said don't do anything. It's still experimental. So this is what was in mid-2000s. So what has changed since then? Of course, antenatal steroid use, which was being used in the 90s, has become more common. People have been auditing it. More and more women are getting it. And hypothermia was recognized as a big killer for these babies. People have put in things in place to reduce that. Surfactant replacement was becoming more common and more judicious. Increasing use of non-invasive ventilation, which is known to improve outcomes, and less use of postnatal corticosteroids. All this have an impact on the long-term outcome. So I look at some studies in the 21st century of how these babies are doing. So we had the Epicure 2 and EpiPage 2, then we had the Express from Sweden, and of course, Sarah has more knowledge of this data from the NICHT network. They've been looking at it rigorously for the last many years. So Epicure 2, this was again looking at babies born in 2006. They started looking at all the babies from 22 weeks, like in the previous cohort. And they were trying to examine the changes in clinical practice. Have they made a difference? And they were looking also at the kind of demography of the mothers and also the approaches in different parts of the country, in the UK and Wales. So as expected, antenatal steroids use had gone up significantly. More babies were in a better condition at 5 minutes. Hypothermia significantly reduced and increased surfactant use, and it was a significant difference. And when they looked at short-term survival data, this is survival to discharge, at every gestation apart from 22 weeks, there was a 10% increase in survival. That's only survival. We'll come to the long-term development in a minute. So if you look at the overall cohort, around 10% increase from the whole cohort from 22 to 26 weeks of admitted babies as compared to 95. But when they looked at it, it was apparent the survival advantage was in the first 7 days. So basically, it was a better condition at birth, looking after the mothers. So it's that intention or survival-focused care which had improved. Short-term morbidity is not a huge difference apart from treated retinopathy of prematurity going up in the second cohort. That's probably because more and more extreme premature babies were surviving. You would expect morbidities to go up as well. And the short-term development at 3 years, we don't have the long-term Epicure data just yet. So there were more babies surviving without disability at 24 and 25 weeks, but the proportion surviving with severe disability had increased as well. And the authors did comment that compared to the 1995 data, there was our follow-up was not complete, and there might have been a bias towards better outcomes. But still, it's encouraging that some babies are surviving without severe disability, but the thing to focus on, there are more babies surviving with severe disability as well. EpiPage, similar. In 2011, there were more babies surviving, almost the same as Epicure, a 10% difference. And their outcomes, when they looked at their cognitive outcomes, are fairly similar to what Epicure was saying. And across the Atlantic, people have been looking at this very carefully. It's not much different. It's almost the same. More and more babies were surviving as the years went by. But there were problems as well. But one important thing which came up from the NICHD data when they looked at it is that gestation alone should not be the benchmark for kind of predicting prognosis. They found that things like the sex of the baby is important, exposure to antenatal steroids, of course, whether singleton or multiples, and higher birth weight. They said a 100-gram increase in weight is almost gives a baby almost the same survival advantage as having an extra week in gestation. So this kind of brings us to the fact that how accurate is gestation age assessment. So they suggested we take all these factors into consideration when we kind of decide what to do with these young ones. That's just a tabular representation of that. Now, if you put together the data from across the world, so places like Japan have been doing this for a long time, looking after very preterm babies and doing a good job about it. So how does the different countries compare? So for example, in Netherlands, even in the 21st century, they don't go towards the extremes of viability to try and save them. So of course, you'll have less babies surviving. But look at, so the focus of today's talk is in these two groups. As you can see, depending on which country you're born in, your chances are higher. So if you're born in Japan, 34% chance you would survive if you're born at 22 weeks. And across the gestation spectrum, the survival is better as well. So this is again looking only at survival. And if you look at our local data, I've just plotted the same, extrapolated our local data from Cornish over around 6 years. That's a dark green line. We are almost similar, apart from at 22 weeks. We are probably at the lower end of the scale. But at other gestations, we have caught up, and I'm sure if you looked at data from TAWAM or SSMC, it'll be fairly similar. I think we've all started contributing to WARN now, so over the next few years, we'll be able to compare what the local units are doing. The important question is, how are these babies doing in the long term? So if you look at the proportion of babies surviving without moderate to severe disability, as seen at follow-up, this is short-term data up to 3 years. We don't have long-term data yet on these ones. There is a significant proportion, albeit small numbers at 22 weeks, about 33 to 40%, depending on where you are, and even 50% in Japan, who are surviving without severe disability. So what has happened in the last few years? The attitudes have changed, mainly in the West. And what I'm trying to explore is how pertinent is that in our setup? Are we ready to kind of embrace those changes yet? So the underlying principles of these thoughts and the changing attitudes is people recognizing gestational age assessment is an imprecise science, even with the first trimester scanning, this trimester scanning, it can have a variation of up to 4 days. So a baby at 22 plus 6 weeks might actually be 23 plus 4, or even younger, we don't know. Unless it's an IVF pregnancy where we know exactly when the embryo was implanted, we can never be sure. We talk about LMP up to 2 weeks. And understanding that fetal development is a continuum. And also, is there a genetic predisposition to better outcomes? What we see in Japan, is it just because of what they do, or are Japanese babies genetically programmed to do better? We don't know. And steroids. People are now getting more comfortable with using steroids at younger gestations. We had a big debate in our team of 11 consultants whether we should be doing this or not. There's no RCT evidence below 26 weeks, but we still use it at 24 weeks. So a lot of the physicians across the pond do say, if you're planning to resuscitate a 22-weeker, and if the family wants it, you give steroids. And there's some evidence it has a survival advantage. But is that the right thing? We don't know yet. And also this concept of survival-focused care. So if you kind of decide, yes, we're going to do something for this baby, do everything you can. That includes antenatal steroids, maybe magnesium sulfate. We are talking at 22 weeks. Offering mothers cesarean sections, taking into consideration this might impact her reproductive health and for the rest of her life. So things have changed. So based on all these changes coming in the UK, they looked at the guidelines again. And in 2019, BAPM kind of produced this guideline saying that neonatal stabilization may be considered in babies below 23 weeks, depending on assessment of risk and discussion with parents. And this is very similar to what the Americans have been doing since 2015. So what BAPM came up with is this framework saying that you assess the risk. If a baby is at 22 weeks, is it 22 plus 1, 22 plus 6? If you're at the lower end of the spectrum, you're extremely high risk. Then you look at the other non-modifiable risk factors, like is it at the beginning of the week? What is the growth of the fetus? What is the sex of the fetus? Are there multiples or singletons? And then the modifiable risk factors which we can do, like the survival-focused care, which you give antenatally to the mothers, and also the setting of birth. So, for example, in Abu Dhabi, the chance of a 23-weeker who is born in a kind of semi-rural hospital in the western region with very kind of insufficient staffing will be quite different to a baby born in the city with a fully staffed tertiary or quaternary NICU. So all that plays a part. And based on that, they've made recommendations. So extremely high risk, if you had these sort of risk factors, so if you are very premature, more towards the lower end of the 22-week spectrum, fetal growth restriction, a boy, multiples, and then all the way they went down to moderate risk. And based on that, they put this framework saying that if it's a moderate risk, offer life-sustaining treatment. Most of the 22-weekers wouldn't fall into that category. They would automatically be high risk or extremely high risk. And it's a discussion and partnership with parents. That's all well and good. So what's been happening since this change in this thought process? So in the US, the guidelines changed somewhere here, and you could immediately see the survival-focused care at 22 weeks was increasing. And so were the survivors. So it went up from 6% to 17%, a tripling of the survival. In the UK, they looked at that once BAPM had put in their guidelines in 2019, and immediately resuscitation and survival-focused care being given to the 22-weekers at increase. And as expected in the UK as well, the survival increased. Even as a percentage of the babies were alive at the onset of labor and the live births. But that's just the survival. What are the long-term outcomes? So this was a meta-analysis published in 2019. So at 22 weeks, this is what we are focusing on here, whether we should be going down to that limit or not. A fourth of the babies survived without major impairment. And as you went across the gestation spectrum, your chances of surviving without any major impairment increased, as expected. But still, 75% of them did badly. And these are only short-term outcomes. And as I showed in the previous slides, these problems persist into later childhood and adulthood. And if we start doing that here as a society and the medical and the educational system here, is it ready to take on such challenges? And when you look at Japan, They've been doing this for a long time, and they looked at the outcomes in 22 weekers in 2 time epochs. And what they found is that the survival definitely had improved, but so had the moderate to severe neurodevelopmental impairment. So more babies had survived in Japan between the 2 time periods, but the babies surviving with moderate to severe neurodevelopmental impairment went up from 34% to 46%. So it is a tale of caution. And this is the Victorian study from Australia. They were looking at, again, they looked at 3 epochs, one in early 90s, then mid-90s, and in the 21st century. What you can see, of course, survival had increased, but in each epoch, both physical and intellectual impairment had increased as a proportion of the survivors. So most children surviving, but more children surviving with impairments as well. And this, we had looked at our data because this debate was raging in the last few years, saying that should we be looking at 22 weekers or not? Should we be providing them with intensive care? So this is all credit to our ex-colleague Andrew Meeks, who used to maintain this database religiously before he left. So we kind of interrogated his database. We found that we had 77 live births in 10 years or so at 22 weeks, out of which 4 survived. And as a proportion of admissions, that was 20%, very similar to what others were reporting. But as a proportion of live births, it was only 5.4%. When we kind of dredged up the electronic medical records, we don't have a very organized follow-up program, unfortunately, in this country for a lot of reasons. But when we looked at what was happening to them, all of them went home in oxygen. All of them had moderate to severe IVH or bad-looking brain scans with cerebellar hypoplasia and so on and so forth. And all of them had spastic cerebral palsy of varying severity. So not a great outcome. So in summary, this is what's been happening over the last 3 decades. Survival has been improving, definitely, and the most gains are about 23 weeks. 22-week survival is improving, but is it a kind of good survival? We don't know yet. Only long-term data can answer that. And survival also depends on where you're born, depends on what the policies are, what the thinking of the medical fraternity there is. And the important thing, I always reiterate, the long-term outcomes of these extreme preterms, especially at the extreme margins, is largely uncharted territory so far. As the years go by, we'll know more. So, what should we be doing here in the UAE? Now, when you think about resuscitation at the margins of viability, ethics is only one aspect of it. There are lots of other things to consider: the societal, the economical, the legal considerations of where you're working. And because of that, as I have shown, outcomes vary from country to country. And the importance of having some local consensus guideline is to reduce the variation in care we provide to these infants. So it's important that we look at this. So when we start looking into this, what are the challenges? As physicians, we are trained to preserve life. But is that preserving life at all costs? What quality of life is acceptable for these babies? And if we say we are going to kind of save only the best ones of them, is that discriminating against disability? Or should we be kind of reducing undue suffering in the face of near or certain poor outcomes? And add to that mixed parental preferences, which plays a big role here. While training in the West, a lot of us, we are told we don't practice paternalistic medicine, but it does happen here. And parents do lean on us to kind of tell them what to do. And this is a concept which is coming into vogue in the West, saying postpone withholding for these babies, saying that, okay, you look at them, you start treating, a week down the line, you think these babies are not going to do well, you stop. It won't wash here. Once you're committed in this place, it's very difficult to withdraw, partly because of the laws of the country, partly because of parental expectations, and then you get these babies stuck with you for months and suffering under our very eyes. And there are a lot of uncertainties which I've talked about, like the imposition of gestational age assessment. And we don't, unfortunately, have long-term outcome data here. And there's a dire need to collect that. And also it's important to look at what we've looked at. If we start only looking at our own data and not compare to what's happening internationally, that it becomes a self-perpetuating bias, saying that we can't do anything about these babies, leave them alone. So that's what we have embarked in this country now. We are at least the SAHA network is part of WARN now. All the hospitals will be able to compare and to look at what's happening around the world and should we adopt it here. And that's the purpose of this talk. So that brings us to a bit of medical ethics. I'll rush through this. Of course, our preterm babies have no autonomy. We are their advocates along with the parents. And just look at the concept of justice. For example, when we talk about justice in medical care, it's about doing not only good for the individual, but also the community as a whole. Because resources are not infinite, and we have to kind of target where we spend these resources. So the need to ration tailor for the maximum benefit for the most people in the community. In preterm care, it depends on what your funding systems are. Where I came from, the UK, it was free at the point of delivery, so we didn't have to think much about what parents could afford or not. But here and the US, where it's largely insurance funded, that becomes an issue. And it's also important to understand how it affects the healthcare economy. For example, the DRGs is kind of fixed for below 1,000 grams. It doesn't differentiate between a 22-weeker and a 26-weeker. If you look at it, you get a fixed amount of money. So you start kind of resuscitating these 22-weekers in this country where you cannot stop like you could have done in the UK or US. You're going to exhaust your DRG in no time. That ultimately leads to burden on the hospitals, the viability of healthcare organizations, but not to forget the cost of the families themselves, the emotional, the social, the financial, not only when the baby is born, in the long term. Are we as a community ready to kind of face that? So in the UAE context, as I've shown from the Corniche data, our survival is improving about 23 weeks. But survival is not the only outcome to consider. We need to look at what the outcomes of these babies are in the long term, and unfortunately, we don't have that data here. Will we be able to match what the West is doing? I don't think so, because we don't simply have the infrastructure for the social support, for the educational support, the disability provisions. It is improving, but nowhere near where it should be. The follow-up programs, like the one the NICHD runs in the US. So we need to learn to walk before we run, is what I always say. And the Swedish and Japanese outcomes, the proponents of 22-weekers always talk about, still remains aspirational. So, and coming back to why we need national guidance, to kind of set down healthcare priorities, it has to be within the context of where we work, and also medical liability law. So let's say we say, yeah, we are going to resuscitate all 22-weekers. Before you know it, there will be quite a few babies who are not doing well, and the physicians and hospitals will be held responsible for the poor outcomes. So all this needs to be taken into consideration before we lay down our own guidance. So again, I ask myself the question, is it time to rethink the margins of viability locally? Maybe, but not yet. Thank you.
Thank you, Dr. Hafiz. So next, I'd like to welcome Dr. Iviano. He is the Director of Neonatology Services for Burjeel Holdings UAE and consultant in the neonatal medicine at Burjeel Medical City, Abu Dhabi. He brings with him valuable expertise, along with experience, including multidisciplinary engagement across a variety of spheres, ranging from perinatal, pediatric specialties, including neonatal surgery, cardiology, gastroenterology, just to name a few. I welcome Dr. Iviano to the stage.
Thank you very much for that wonderful introduction. And thank you to the organizers for allowing me to indulge myself by picking this topic. I'm not sure if it's typical. I hope I do it some justice. It's always difficult if you follow Hafiz, so here goes. So I chose the topic of neonatal gram-negative sepsis not because it's particularly more important than any other, but because I think that it's one of these topics where we're still doing much of the same thing. And we should always continue to challenge ourselves in the way that we manage conditions. Now, whether I will be able to elaborate hugely on it will depend on what you think. So, friend or foe, we've lived with bacteria for a long time. Some of them like us, some of them don't. Gram-negative bacteria, however, have developed a somewhat bad reputation. So they're kind of the real natural-born killers in that regard, but not all the time. So I don't want to give them a bad name necessarily. I will talk, not necessarily in this order, but I'll talk about epidemiology, look at the significance of this situation, a bit of historical perspective, and go into pathophysiology, antibiotic resistance, which I should actually put in capital letters. This is the big issue for us. Treatment options, which is where I think we need to continue to reconsider what we're doing, and potential novel treatments. And there have been trials, which we will talk about very briefly as well. So as I alluded to, bacteria have coexisted with us for millennia, and they've coexisted with other multicellular organisms for billions of years, mostly as commensals, sometimes as symbiotes, but occasionally they'll cause disease, including sepsis, which is significant. And neonates appear, and I use the word appear to be a particularly susceptible subgroup, and there are some relative myths about the status of the neonatal immune system, which I think are potentially exaggerated. I won't necessarily go into it in this talk, but I think is again something that we have to think about. Antibiotics were invented or discovered about almost 100 years ago. They have evolved over time with the use of research and pharmaceutical companies, but we still lag behind the ability for bacteria to evade our efforts to rid ourselves of the bad ones. So this is a problem, and it's a big problem. It's not so much a big problem in developed countries and high-income countries. It's a massive problem in lower middle-income countries. And I think we have a responsibility when we talk about our issues to also be mindful not to forget about the issues that might affect low and middle-income countries more than they affect us. So you will find that I will refer to them as we go along. So up to 36% of neonatal deaths globally are caused by infection. Gram-positives are actually more common, which is a good thing, but gram-negatives are more likely to result, gram-negative infections are more likely to result in severe sepsis and mortality. The case fatality actually varies incredibly. So although I've quoted here 7% versus 13% for gram-positive versus gram-negatives, in some instances it's much more than that. It's about double. Overall, it contributes to over 200,000 deaths per year globally, and some figures quote over 300,000 deaths per year globally. So the problem we have, as I mentioned before, is that it's complicated by multi-drug resistance. We tend to characterize infections in neonates by whether they are early onset or late onset sepsis. And there are a few definitions, but typically first 3 days after birth, early onset, and beyond that, late onset sepsis. If you look at the characteristics of the bacteria that are involved, in early onset sepsis in the higher income countries, you tend to find group B strep and E. coli. And approximately 1/3 of early onset sepsis would be caused by gram-negative bacteria. These numbers change when you look at late onset sepsis, and the bacteria also change. So in late onset sepsis, and many of you will be aware of this, you will tend to find coagulase-negative Staph aureus, which may or may not be methicillin resistant, and gram-negative organisms in that context contribute probably 15 to 30% of late onset sepsis in the high-income countries. The organisms are either E. coli, Klebsiella, the occasional Acinetobacter, perhaps Serratia, both of which are actually quite deadly, but not common, thankfully. In the low middle-income countries, it's a whole different picture entirely. So if you look at studies from China, Brazil, where they have mainly Enterobacteriales, in some parts of sub-Saharan Africa, it's about 40% neonatal infections which are secondary to gram-negative organisms. And in India, this figure is even higher. So you're looking at 65% plus. There are obviously geographical reasons for it. but there's also the use of antibiotics and perhaps in some circumstances the lack of antimicrobial stewardship in the hospital settings and easy access be outside of the hospital as well. Overall, though, collectively, these data point to one thing. There's a significant burden of infections due to gram-negative organisms in neonates, although particularly so in low middle-income countries. The classic risk factors are that you are low birth weight and you have low gestation. If you're extremely low birth weight or very low birth weight, then you typically are at higher risk. I take issue with that a little bit because if you break down the incidence of infections in these babies, there are a few factors which present themselves later on, which are not entirely because of the gestation and the age, but because of some of the interventions and some of the complications associated with the gestation and the age. So it's not so much just the gestation. So an example would be typically babies who have developed TPN-related cholestasis are at higher risk for infection. Now the TPN-related cholestasis is because we've had to give them TPN. If we could get away with not giving them TPN and they didn't have cholestasis, that degree of risk would be removed from their overall risk. So it's not that straightforward, in my opinion. That said, there are lots of other things to take into consideration. We give them prolonged antibiotics, we ruin their microbiota. Again, sometimes we feel it's unavoidable. They have plastic in them, central venous catheters and other catheters as well. And then there are other center-related risks, which again, I think are not necessarily always taken into consideration. Overcrowding and understaffing is a major problem. And it is consistently ignored in spite of the fact that I think the vast majority of clinicians are very aware of this and they make very vociferous complaints about it. I've worked in various very busy setups. I worked with Hafiz, and the proximity, let me use that terminology, between the babies that I looked after there, it may have changed. Maybe you've got your big unit now. No? Okay, so you're still the same thing. The proximity between babies is impressive. Okay, if I stretch my elbows, I'll touch 2 incubators. That's just the way that it had to be, but clearly that's not appropriate. Besides understaffing and overcrowding is also rapid turnover, which again is not taken into consideration. When you take a baby onto the unit and you have to stabilize the baby, even if you send that baby away in 24 hours time, it has taken up nursing, physician time, and taken away time from some of the other babies. So rapid turnover is also another problem which we don't necessarily consider appropriately. I like the bit about artificial fingernails. I don't know if you missed it there. But artificial fingernails, we talk about hand hygiene. So sometimes we have situations where people feel that so long as I wash my hands properly, it's fine. Well, not necessarily so. If you have things attached to your nails, then it doesn't matter how well you wash your hands. That is always going to be a source of infection. All of this to say, at the end of the day, gram-negative organisms have a higher risk for mortality for our newborns. That's what we're concerned about. We have certain challenges. If you look at adult and pediatric literature, their definition of sepsis is very clear. They define sepsis in relation to systemic inflammatory reactions. We don't really do that in neonatology. For us, sepsis is generally fairly straightforward, defined as a positive blood culture, plus or minus some symptomatology, which will vary. And there was a very nice review which looked at the number of definitions in the various studies that have been conducted, which of course compounds things for us, because if you don't have consistency in your definition, it makes it even trickier for you to compare and contrast studies. But again, I think that again, this is something that probably needs a review, where perhaps an expert panel agrees on a definition which is either in keeping with pediatrics and adult medicine, where you have cultural results with other features that are consistently applied when sepsis is defined. So, big issue which I will focus on a lot is multi-drug resistance. One of the commonest drug resistance patterns that we have is the beta-lactamase enzyme presence. They're encoded by chromosomal genes, and also by genes present on non-chromosomal and extrachromosomal elements, including plasmids and transporons. And the transporons are mainly responsible for the worldwide spread of ESBLs and carbapenemase enzymes. A few years ago, we carried out a questionnaire survey in the UK looking at the incidence of ESBL because we had a problem on our unit. We had an outbreak. And so we wondered whether we were alone in this outbreak or if there were others as well. Having had a chat with our local other level 3 service, we decided to put out a questionnaire. And to our surprise, ESBL was a major problem in the UK, and this is going back 2008, 2009, a major problem. But what was happening was that it wasn't being reported. So nobody really knew that it was a problem. But when we got our questionnaire back, we found one service, again a level 3 service, where literally almost every baby on the unit had ESBL. But they, as a consequence, they of course had to carry out an RCA, and they found out that it was because of their the sewage system on the unit, which was broken and they hadn't realized it. So that had really caused contamination. And contamination occurs in circumstances that we sometimes don't appreciate. So once it's on the unit and the babies have ESBL, even if they're well, they're carrying it and it's transmissible. Okay? So it just carries on from parents to the next child and so on and so forth. I'm mindful of time, so I'll skip some slides. I have quite a few slides. So there are other aspects of resistance patterns. Porins, which are channels within the bacterial cell membrane, they allow antibiotics to traverse the bacterial cell membrane. And there are efflux pumps, which remove antibiotics from the bacterial cell, which cause resistance to multiple classes of antibiotics. So the efflux pumps don't select. If an antibiotic goes in, they will attempt to throw it back out. And they're pretty successful as well at this particular aspect of resistance development. Worryingly for us is carbapenemase resistance, because we haven't had, until very, very recently, a new development in a new class of antibiotics. So there is a new class of antibiotics, escapes my mind, but this is a very recent development. As we all understand and appreciate, it takes a lot of time, a lot of money, a lot of effort to develop pharmaceutical agents, and antibiotics no less so. They're not a priority. The pharmaceutical industry is a business, and antibiotics are not necessarily a priority. There are other better paying products that are under development. So we don't often get an antibiotic that is a different class of antibiotic that's developed. What we do have sometimes is that an additional compound is added to an antibiotic, which is cheaper and easier to develop. So this is something that we need to worry about. We've seen a fair bit of Klebsiella, which is ESBL positive. We've also seen E. coli as well, which is ESBL positive. Another issue we have is that most studies reporting antimicrobial resistance in NICUs are single-center reports, like we described. It was our problem, we reported it, and that was it. We did a survey, and that's where it ended. So multi-center collaborative studies are not necessarily there, and I don't understand why we can't have a repository. Actually, DOH has a reasonably good collection of the antimicrobial spectrum here in Abu Dhabi, which I highly commend. I'm assuming that it is still running, which is excellent. But this isn't necessarily always the case. It might be because this is a relatively small area, so it's easy for them to do it, or it might be because the DOH feel that this is very important and they keep track of it. There was a multi-center study in the US looking at a number of tertiary NICUs, and they found that 25% of neonatal gram-negative pathogens were not susceptible to more than one commonly used antimicrobial. So 25% is actually a pretty high number if you're treating something like infections. I'll skip that. In Asia, you're talking about 50 to 80% of screened neonates. That's frightening. If 80% of your screened babies have got a resistant organism, then you're truly stuck. And typically, there are very high rates of resistance to ampicillin, aminoglycosides, not so much to gentamicin, which is a good thing, but then we don't often use gentamicin, interestingly enough, as a second-line medication. Maybe you do, but most people often go for something different, second line. But actually, aminoglycosides remain pretty resistant to resistance, okay? So it's probably something we should bear in mind. So in 2020, so 4 years ago, the CDC said, look, this is a big problem. We need to work on prevention of MDRs. Now, increasingly, more hospitals are ensuring that antimicrobial stewardship is a major component of their practice. In our hospital, you're obliged, and it's a very good thing, to have an antimicrobial stewardship champion from your department. It's compulsory. And it's great because now we are more careful about asking about treatment options, even though we have protocols. And I think that's important. And we're better now at asking for advice when we come across a slightly different picture, either an organism that we're not particularly familiar with. In the past, we might look it up and treat accordingly. But now we'll simply ask our microbiologist or our pediatric infectious diseases consultant for advice. And I think this is the appropriate way to go. So pathogens cause disease through various factors. And I'll skip along because I'm mindful of the time. And these virulence factors are quite important. And they're important because we know that this is what causes the problem. It's not the bacterium generally, especially in gram-negative bacteria, in bacterial infection. It's typically the reaction that they create. And they don't tend to create that from antigen. They create that from toxin release, usually. So there are a number of various bacterial toxins to consider. Type 1 toxins or superantigens, type 2, which are hemolysins and phospholipases, and type 3s, which are AB toxins. But the toxin that I think we should be most concerned about is endotoxin. And we know that for a fact. And an endotoxin has been identified for a very long time, over 100 years, which is pretty impressive. So we are aware of its existence, we're aware of its importance, and we are aware of the fact that endotoxin, especially LPS, is a major cause of severe illness, morbidity, and mortality. It makes up 75% of the outer membrane of gram-negative bacteria. So when they die, they release this. Now, bacteria, of course, die regularly, but generally the body is able to cope with it. And when they die, they will release LPS, but in small quantities. And I'll come back to this a little later on. I don't know if you can see that. So that's just the component of, that's just the component of LPS. So this is where the problem lies, and more especially here. Lipid A is the component that causes the most damage and injury. So we are used, even newborns are capable of identifying the presence of an unusual organism or antigen. So they're not that naive. We talk about newborn immunity being naive, but the innate immunity is actually not that naive. So they're perfectly capable of doing this. And the fact that they go on to develop severe sepsis proves that point, that they can recognize and respond in a fairly similar way to older children and adults. So typically what happens, the inflammatory response is needed to clear bacteria, as I've discussed. In bloodstream infection, presence of lipid A may lead to endotoxic shock. This is your typical normal response. This is what happens when you have an exaggerated response, either because you're overwhelmed, your system is overwhelmed by LPS, and you're unable to clear it quickly enough to prevent it from producing an exaggerated response. And ultimately what happens is that you end up with septic shock and death. So, what do we tend to treat with? We talked very briefly, piperacillin, tazobactam, some aminoglycoside cover perhaps carbapenems when we're really concerned. And sometimes we jump in with carbapenem quite early on because we feel that if we can just kill the bacteria, we'll be fine. So we've gone on to develop better carbapenems, if you like, and we don't know how long they'll remain better for. But this is where my question comes. We literally always, almost always, assume that in order for us to efficiently or effectively treat a baby with suspected or confirmed gram-negative organisms, that we must use a bactericidal. There's evidence that bactericidal antibiotics are not necessarily better than bacteriostatic antibiotics. There are gram-positive organisms that we never treat with bactericidals. You will not treat Staph pantomvalentine leukocidin with a bactericidal antibiotic because you will kill the child. So it begs the question, if we have that rationale for certain gram-positive organisms because they produce toxins, why don't we consider that rationale for gram-negative organisms that produce toxins? So this is kind of the crux of my talk. We've tried other things. The INIS trial didn't show any benefit. Immunoglobulins, some people still use it, by the way. GM-CSF, G-CSF, didn't really show any benefit. It improves neutropenia in very small preterm babies. It gives them some measure of benefit, but it's not statistically significant. But some people still use it. So, back to my LPS. Stabilin receptors clear LPS naturally via the liver, efficiently. And as far back as 1999, there was a very eloquent paper that literally asked the question. It's a very big paper, so it's not something you put up here. Literally asked the question, why are we not targeting the source of the problem? So we've targeted everything else, but left out the actual source, which is LPS. And we know how it works, and we know how to block it. So stabilin receptors are the natural way of clearing LPS. They're quite efficient, they work well. I think the only proviso for stabilin receptors would be that if you have liver dysfunction, then it's quite possible that you are at risk because your liver cells will not do the work that they're meant to do in this regard. So that's probably something to bear in mind. And we know that if you have cirrhosis or any other liver disease, that you're at increased, even TPN-related cholestasis, you're at increased risk of infection, particularly gut organisms. So I think I'm just about going to make it on time. So the take-home message for me is this. Neonatal sepsis remains a problem. We all know that. MDRs are a problem. Again, we all know that. Bactericidal antibiotics continue to be the therapy of choice. I'm not sure it should be, necessarily. There's some evidence that shows the similar efficacy with bacteriostatic antibiotics. Perhaps a combination might be something to consider. The role of endotoxins in causing mortality and morbidity is now well established, much better understood, and should be considered when we look at alternative modalities for treatment. So, as with everything else, further research is required into new modalities of treatment beyond newer antibiotic classes, in my opinion. LPS appears currently, at least, to be a very appropriate target for future therapy development. And stabilin receptors, which I've just talked about very briefly, have been identified as an important component of LPS activity modulation. Another thing that has been considered, which I haven't actually put on the slides, is synthetic lipid A analogs. If you remember, I said the lipid A component of LPS was the major source that drives the endotoxic reaction. So synthetic lipid analogs block the ability of the lipid A to attach to the cell wall. So maybe a combination therapy with bactericidal and bacteriostatic antibiotics could also be another appropriate focus for an academically minded neonatologist. And with that, I'd like to end my presentation. Thank you.
I invite the speakers to the stage for questions, please. Dr. Hafiz, Dr. Niaz, Dr. Mughis, Dr. Viano.
So, Nisha, can I ask the first question or not?
Let them have a seat first.
Okay. They can answer me when they are standing. So, it's a very thought-provoking. I have a question for everybody, but my target is Niaz and Hafiz. So first, Niaz, I'm a very simple person. The question is that 26-year-old is already grown up, and you transplant 1.5 kilogram baby kidneys. How those kidneys grow? Is because of perfusion? You said 6 weeks it grows in the adult body. I thought our body grow all together. Or it's like my abdomen who is growing and all other part is not growing.
No, so it's good that I also think very simply. So I didn't know these facts. So I went back to the drawing board and I studied embryology again. And what we found that we are born with adult kidneys. The number of nephrons are finalized at 36 weeks. So when we grow into an adult, your size or our size, in fact, the number of nephrons are less than what we were born with because of all the environmental damage we have done.
Sure.
So all you have to do with these kidneys and put them in a right environment. So it is as simple as that. So that's what I said, no long-term diabetes, no peripheral vascular disease, no hypertension. If you protect these kidneys, they will grow with hypertrophy, not hyperplasia.
Sure.
Yeah.
Hafiz, one question. Sorry, Dua. What should we do now?
I think we should continue what we're doing and focus on collecting more data on the long-term outcomes of what we're already doing.
See, I am, and I don't know, you came after me, but I am here more than now 14 years. And still, our data of less than 24 weeks is horrendous. I am telling you, if somebody else telling you that they are saving 22 weeker and this thing, they are just mimicking it.
Yeah, so I think at least our setup is not ready to take on those extreme preterm babies just yet. We continue focusing on the babies we're focusing on, optimize their care, collect data, and then look at how we're doing that before we go further down. That's my proposal.
Thank you. Dr. Dua?
Yeah. Thank you for this nice session as well. Thank you, Dr. Hafiz, for your comprehensive review. I was hoping that after your session, your presentation, I will have answers to my question, but you left me more and more confused on those between 22 and 24 weeks, what to do. Do you feel now there is an urgent need to develop local guidelines for at least Emirate of Abu Dhabi? For example, for level 3 units, what kind of support should be offered and to what extent this support can reach for those between 22 and 24 weeks. Because what is available in level 3 unit, for example, in Corniche, is not really different 20 kilometers away from another level 3 unit in both private and government institution. What do you think?
The simple answer is absolutely. We need local guidance so that we all do the same thing, so that we are all held up to the same standard. But of course, these are not black and white. It can never be. So there will be a bit of ambiguity always, and we need to work within that ambiguity, but some sort of local guidance is vital.
So I hope these meetings will be like a motivation for the key opinion leaders in SAHA or DOH to move on and have set of guidelines not only for those are at perinatal viability, but for other aspects of neonate and other aspects of neonatal care. Thank you. Thank you so much.
We have another
if you-
question here.
Can I make a comment on that if you don't mind?
Sure.
So, to Dr. Dua and Dr. Hafiz, absolutely agree. I think, though, that we have to focus on collecting the data. We cannot be shy about this, okay? If you don't have data, then what is it that you're putting a protocol for? What are you proposing? Against what? So we have the data, it's there. The question is, are we prepared to share? Okay? If we're not prepared to share, personally, I would have not a great deal of interest in getting involved in the preparation of a protocol when ultimately you can't audit that protocol because people are not sharing their data. People have to be prepared to share their data if we are to have a common protocol. But I totally agree. I think we should have a common protocol, but we should reveal our data.
Thank you. Yes, doctor?
It was very interesting. We were talking about limit of viability. So I'm still not sure. Only talking about 22 weeks to 20 or 23.
I can't hear you very
Or
well.
were you specifically talking about 22 weeks? Because I'm just trying to see what argument you're making. Because you showed some of the data about the 22-weeker, from Corniche. But I think it's really interesting. If you just show the data from 2022, which is Edward Bell, who actually went and looked at the 2 years follow-up of the same study that was done for the NHS. And that was very interesting. There is no difference between the outcome of 22-weeker and 23-weeker. So why we are not also saying we need to do the same thing for 23-weekers? Because 1 year survival, 1 year still in hospital, yeah? All of these babies are exactly the same thing. 50% of them will be exactly the same thing. So I think we need to look. We seem to be obstetrician very aggressive at 23 weeks currently. We are very aggressive at 23 weeks, but actually for 22-weekers, we are not. I think there are some 22-weekers who actually probably had a better antenatal, less complication. If we aggressive management, that's obstetrician from including steroid, including antibiotic, including mag sulfate, including cesarean section, and the pediatrician resuscitating aggressively the one who's responding, yeah? And that's including ventilation, even epinephrine. These babies, if they're aggressively resuscitated and managed, there is 30% survival.
Yep.
The one who are not and left alone is only 10% survival.
Yeah.
So I think we need to do the same thing for 23-weekers. I personally think even at 23 weeks, you need to look at the patient, have a discussion with the parents, and then make that decision. I think protocols and things are not really straight when it comes at that.
Yeah, absolutely. There's lots of variation, as I said, and a lot of unknowns. For example, when we talk about gestational age, people call it gestational ageism. We can never be certain. So we have to look at the baby after the baby is born, and we are certain this is a very premature, previable baby, probably go down the route of comfort care. So yes, I agree. They're not far different, but in our current setup, we are getting more and more comfortable looking after 23-weekers we have over the years. Whether we should push that down further or put a stop there.
Because 24-weekers different. They are really different than 22, 20. Because 6 out of 10 will survive.
Yeah.
1 in 7 will have severe disability. Comparing to a 22-weeker or 23, between 1 to 4
Yeah.
will survive. And actually, also significant of them will have
Yeah.
severe disability.
Yeah.
Thank you.
Thank you. We'll take a question from the other side.
Yeah, thank you. Very good, stimulating discussion. I'll just add something to that. When we're talking about local guidelines, at least in Abu Dhabi, from this January onwards, the JODA is collecting data above 22 weeks for corrected and uncorrected mortality. So that has changed from the previous year, where 24 weeks and 500 gram was the data collection point. Now is 22 weeks and 500 grams. So here lies the thing, that will put pressure on certain segments. And, Iviano, we'll get the data from there. So that's one thing, like we don't have, like previously also, even with 24 weeks, we never had any clear guidance or any local guidance about what is the cutoff. So everybody assumed that the JODA collecting data point was the cutoff. Now the goalpost has moved. So already, while we are debating this, the goalpost has been moved by a regulator. The second thing is, that is open to everybody. The second thing is about parental expectation. If you Google, Canadian network, if you look at the data from 2019 onwards, at least I've seen, 50% survival, 40 to 50% survival rate at 22 weeks. They are talking about. Again, long-term data is not there, but that skews the expectations of parents who will come and say, I want everything to be done. So what are your takes on these two?
That's exactly what I was saying. We need good local data. That will be the step forward, what Iviano was trying to reiterate. Survival is only one aspect of the whole jigsaw. Long-term survival is long-term outcomes are more important. We need to collect that urgently. And we need to be realistic about what's achievable. We need to have hospital-level data to kind of tell parents, this is what we can achieve here and what the outcomes are. There are some moves in that direction now. Hopefully, over the coming years, we'll have more data, and we might be able to counsel these parents better, is what I think.
And the first part, JODA will put pressure on all the hospitals. The JODA data collection has implications for our Muashir ranking, every other thing. And those mortalities, when they come into your data point for JODA, that will put pressures on everybody.
True.
Thank you very much. I think we'll finish the session here. We'll break for lunch now. Thank you very much.
Thank you.